Welcome back to another edition of the Hart2Heart Podcast, and my guest today is Dr. Sharon Koivu. She's actually a physician in my town in London, Ontario, where I'm currently living, and this is actually the place where the first city where Safe Supply was introduced, and that's really when I talked to Dr. Sharon Koivu about here today. She's actually an addiction specialist. She knows a lot about addiction medicine. She's been involved with caring with patients, also involved with creating different policies, and I'm very, very excited to chat with her today. So Dr. Koivu, welcome to the show.
Thank you very much. It's nice to be here.
So I know we kind of, briefly chatted before the show. We both kind of feel like we, shouldn't be having this conversation or need to be having this conversation today. But unfortunately, with what's going on, we do feel like, we need to get this message out there. So, I was very concerned with, Safe Supply just from, kind of a logical point of view at first, because, I didn't really see this is a potentially a solution, of essentially putting more drugs into the system. But before I kind of get into why it's wrong and what we need to maybe do to correct it, maybe you can just give the audience first just a brief background about yourself, and then we can get into potentially why Safe Supply was started in the first place.
Well, thank you. I've been a physician now for 39 years. I did family practice for a number of years. And actually, I've also been an acting medical officer of health for 10 years. So very involved with health protection, health promotion, and harm reduction as a mandate of that position. I was working in palliative care as well as being a chronic pain physician when I started seeing a lot of people dying from particularly infectious complications of injection drug use from, at that time, it was mostly abusing hydromorphcontin. And that gave me an interest in addiction because I was realizing we didn't have, at a tertiary care center, we didn't have an addiction program at all. And
when was that?
That was, it was 2011 that I started developing the interest. So I did a lot of courses and essentially developed my added competency in my certificate of added competency in addiction. So I've been offering an addiction service, doing consults in addiction medicine since 2012.
Excellent.
So that does overlap with the kind of what I was seeing was related to what I sometimes refer to as the Purdue-driven Oxycontin opioid crisis. Saw the fallout and ramifications from that. I also saw what happened when we didn't respond to that properly, because when Oxycontin came off the market, we started using hydromorphcontin, and it had its own consequences. So I've been there when we've kind of played whack-a-mole, trying to use a drug to fix another drug and just create a whole new problem. We've been here before.
Yeah, so that's kind of interesting. So, Oxycontin was the first drug, and then you're kind of saying now that even when Dilaudid was pushed right after, you kind of thought, maybe this isn't a good idea as well. Like, then before even Safe Supply was a thing, like you were sort of worried a little bit about Dilaudid becoming a big issue before. Is that correct?
It was actually not Dilaudid. Okay. It was the long-acting, which is hydromorphcontin.
Hydromorphcontin, okay.
And so Oxycontin was long-acting. And when it came off the market, London had a high percentage of specialists in chronic pain who really encouraged the use of opioids. It was quite a center for opioid prescribing during the kind of early 2000s. And when Oxycontin was delisted, what really happened here was that people started prescribing hydromorphcontin, so the long-acting capsule. And what we saw from that was that people started getting a heart valve infection. So when I was working, that was what I first identified, was that the long-acting was causing a heart valve infection, the right-sided heart valve called tricuspid valve infective endocarditis. Another physician that I was working with also identified that injecting hydromorphcontin was increasing the risk of people getting HIV. And at that time, HIV wasn't particularly thought of anymore as being something that was transmitted through injection drug use. We had a really robust needle exchange program in London at the time, one of the probably per capita the highest in the country, even higher than Vancouver. And so it was kind of a surprise to see that a drug was causing HIV, but we were able to prove that it was the long-acting hydromorphocontin and properties of that were causing both of those. So in 2016, London, the Middlesex London Health Unit actually declared a public health emergency regarding HIV, hepatitis C, and tricuspid valve infective endocarditis. And that was related to the long-acting hydromorphone. So in London, we had lots of responses to try to fix this problem. At the time, I've been able to go back to lots of documentation at the time. We had a drug strategy committee. We had work regarding a supervised injection site. We did not have a problem with fentanyl. We had some problem with patches, and people occasionally overdosed from patches of fentanyl, but we did not have a problem with illicit fentanyl, what's now referred to as illicit or the toxic drug supply.
And on that note, am I correct to say that during that time we were lower than average in Ontario, I think, on illicit drug use or on, illicit fentanyl use? I believe we were lower than average. Okay.
Yes. And if you actually look at the supervised injection site, the paper that was developed as a reason for the injection site that was published in 2017, there is no mention of fentanyl in London. The drug strategy that came out in 2018 mentions fentanyl as being a very, very small problem in London. Hydromorphone was the big problem. Unfortunately, they didn't distinguish between long-acting and short-acting. But what happened in London is that because of the problem with the HIV and hepatitis C and the tricuspid valve endocarditis, we wanted to be creative as to how to rid those problems. That was when the idea of giving out short-acting hydromorphone, which is Dilaudid, as a program specifically targeting sex workers, street-level sex workers, who were felt to be at the highest risk of developing HIV, spreading HIV, and getting endocarditis through injecting the long-acting hydromorphone. We started a program to give out short-acting hydromorphone to those people at risk to get rid of the problem of HIV and endocarditis. And if that was the benchmark, it actually was effective. But what happened was the program kept going and it kept growing. And to get in the program initially, and if you read the initial report, people had to have an opioid use disorder. There was no documentation at all that anyone had to be using fentanyl. So the program expanded and is being talked about as a response to toxic fentanyl, when in fact, toxic fentanyl came to London after the program. And as I say, the work from the Drug Strategy Committee and the Supervised Consumption Site show that wasn't the problem before the program started. But just like when we got rid of OxyContin, hydromorphocontin caused a new problem. Dilaudid caused a huge problem that, yes, it fixed tricuspid valve endocarditis and HIV. We were able to rid the community of that public health emergency, but instead have had a huge crisis of a massive amount of opioid on the street, a massive amount of diversion, more people, more younger people becoming addicted, and so many more problems that are related to, specifically related to diversion from that program. Really the worst catastrophe that I've seen in my entire medical career.
I mean, that's a lot to take in right there. But I mean, just to kind of summarize things, because it's kind of crazy. So we're talking about, 2016, 2017, there's essentially no problem in London with illicit fentanyl use were actually lower than the provincial average. Then 2018, maybe there's like a touch in the legislation about, or in the program about, decreasing fentanyl use. And now the entire program itself, like basically what they're saying is this program exists to eliminate illicit fentanyl use. I mean, that's really what they're saying that their primary objective is. And I will get into, the 2023 paper in June that came out maybe a little bit later, but just on that note, when I did look over that data, even their own data suggests that there was actually an increase in the people in the program injecting fentanyl from 2022 to 2023. So like even within the program themselves, and I know they're saying, oh, it's only like a small number of people, right? But even within the program, it's not working. And clearly you're going to flood the streets with more drugs by doing this. So like, it's not even like a trade-off. It's just both getting worse. It's like the people in the program are getting worse. And then the people outside of the program are going to suffer because there's more of it on the street. Like it just like, I don't see how it adds up like at all. Like I just don't understand it. I can't get anyone to give me any like rational explanation as to why we would continue this program.
I think that when you look at the data that they've collected, most of which is self-reporting, so people in the program self-reporting, they were able to show some improvement. And I will actually say we had an improvement in HIV and endocarditis. But the improvement, they weren't able to say what caused the improvement. So these are people that were now involved in working with healthcare providers. They were involved with getting housing first initiatives through, we had a committee called Street Level Workers at Risk. So we had a housing first initiative for the people in the program. All these wraparound services. So people could get HIV care, they could get wound care, they could get care. So really teasing out whether any of the improvement was from the Dilaudid or what improvement was from actually just being involved in a program that offered other services has never been really addressed. So they were able to show improvement in those in people that were in the program. But how much of that improvement was actually because of diversion? That when you're selling a product that you're getting for free, and at that time, Dilaudid was still probably more like $10 or $20 a pill when it first started, you could get a fairly good tax-free income from selling your product. So how much of the improvement was actually from diversion? It's hard to say, but the improvement that they saw was essentially self-reporting.
And if you don't mind, I'm just kind of curious, and I think other people would be too. So like in terms of the financial rewards that people could get for this program, like say if someone's in the program and they're a heavy user, how many Dilaudids could they get and how much could they sell those for on the street?
Well, that's an interesting question. My experience at the beginning of the program was that most people were getting sort of a 10 to 15 Dilaudid. And at that time, per day. Okay. Oh, yes. And I think it's really important to understand the program because I think a lot of people don't actually understand. So people get a prescription for their Dilaudid. And sometimes there's Cadian as well or other things as well. So the Dilaudid 8 milligrams is the main drug that is used in this program. And to put that into perspective, that's equivalent to about 5 Percocet or about 27 milligrams of oxycodone, depending on which scale you use. But also just putting it into perspective from a pain perspective, that one pill is like what we'd give for an entire day for somebody in pain. I had both my hips replaced at the same time. And the strongest I was prescribed was 2 milligrams of hydromorphone. I was never prescribed 8, in spite of having 2 hips replaced at the same time. So what we give to people who are not on opioids, 8 milligrams, so 1 pill is fairly strong. This is prescribed. People go and pick it up from a pharmacy. Having said that, another thing that I think is important to know is that opioids don't have to be picked up by the person they're prescribed to. So someone else can go to the pharmacy and pick up their drugs. And I know that happens because people can be in the hospital and they've been there for several days, we'll check with the pharmacy. Someone's still picking up their drugs, and that someone is often somebody who's regularly picking up their drugs.
So what is
not
the
only
identification? I mean, maybe I should know this as a physician anyway, but what is the identification that someone has to go through to pick up someone else's drugs?
all you have to do is have identification. So if you have identification, then you can pick up someone else's opioids. Now, I can't tell you how rigidly they check the ID to make sure that the picture on the driver's license matches the person or what they're using. And I can't tell you how regularly they accurately mark down who's picked it up. There are definitely times when trying to find that information out is somewhat of a challenge, although those things are supposed to be documented. But that doesn't prevent someone from picking up someone else's safe supply. So it can be picked up by anyone with ID. And I've heard stories that occasionally it's even picked up by somebody who normally shows up at the pharmacy at 10 o'clock. Somebody has already gone in at 9 o'clock and picked up their supply without their consent. So it's not always necessarily consent driven, although I think those stories are not all that common.
Okay. How many times do you think someone else does pick up someone else's drugs? Like, again, like, would it be hard to guess?
I think that it's still a minority of the time, but it sort of shows that not only is this not witnessed, it's not monitored for even who is picking up the drugs for people. And as I say, when I started, most people were on, I'm going to say, about 15 pills a day. And that was the original recommendation. There was sort of a national committee about safe supply, and they were sort of suggesting that was a number of pills that made sense.
15 8-milligram Dilaudid pills per day?
Yes. I haven't seen that low a number in a long, long time. When I would say most of the people that I've seen in the last, 6 months, sort of in 2024, most people would be on 30 to 40 pills per day of the Dilaudid. Sometimes they were, in addition to that, getting other opioids such as Cadium, which is a long-acting morphine. Occasionally, one of those would be witnessed and everything else would be given to the patient so they could say they had one witnessed dose. But
how much do those drugs cost? Like, how much does one Dilaudid cost, say, from like Shoppers Drug Mart, like to go pick it up? Like,
to be honest, I'm not for the people in the program. It's free,
right?
So it's all covered for the people in the program.
But like, what is the cost, I guess, to the government or to us, like the taxpayers? Like, when we're giving out like 30 to 40 Dilaudid per day, like to one person, like how much government money is being
I actually tried to look at that, and I'm not 100% sure. I think the numbers are fairly low, which I think is possibly a problem in the sense of why it's not been looked at more critically.
True.
Because I think it is only about $1 a pill. So it's not, that adds up. If you think of how many people are getting 40 pills a day and how many are, and that's daily. So for the people, and I think what's also important is that it's not witnessed, but when you're in hospital, often we are witnessing or switching the medication from an oral route to a subcutaneous route so that we know exactly how much people are getting. And most of the time, patients were only able to tolerate a fraction of what they were prescribed. So it's very common for people to be getting 40 Dilaudid 8 milligrams a day, but we're only tolerating 10 or 12 equivalent of those pills a day. So 30 pills a day more, they were prescribed 30 pills a day more than they were actually tolerating. We actually had one person that was only tolerating about 2 a day. And sometimes even when people are on fentanyl, they are selling their drugs, they've sold their Dilaudid to buy fentanyl. They still don't tolerate as much Dilaudid as if they were just getting Dilaudid. So people are selling their drugs and buying fentanyl, but the amount they're prescribed is huge compared to what they actually would tolerate. And this has been a problem in hospital. If you think about it from the perspective of somebody in healthcare, when somebody comes in, you want to make sure you don't put them in withdrawal, but you also don't want to accidentally give them an overdose. And we are taught to reconcile people to their home medication. If we actually prescribed the amount of opioid that is prescribed, like if we in hospital gave them that amount, so switch the oral to sub-Q and gave them the equivalent, we could absolutely cause a toxic overdose and even fatal overdose. And when the program sort of developed, this was a huge issue in hospital because getting that word out to all the residents and making sure people were aware was a challenge. So it became very challenging to know how to treat people in the program. People will tell us that some people will admit they're not taking all of it, but not everyone will because they don't want to lose their script. So it's a challenge to make sure that we know how much somebody is really accurately taking. We don't want to give them an overdose, and we also don't want to put them in withdrawal. So if we guess too high, we could kill them. If we guess too low, they're angry at us, and we're getting hostile calls from people in the community saying that we're not compassionate and we're not caring for those people well enough because they're in withdrawal. So finding that balance between overdose and knowing what the right dose is, knowing that for some people, they are only tolerating, as I say, 10 out of 40 or even 2 out of 40. It's a huge stress for people providing care within the hospital to know what the right guess is or how much opioid. So we can see when people are in a position where we're actually witnessing it, that they are prescribed significantly more than their bodies would be able to tolerate.
I mean, it just seems like it's a very easy program to take advantage of, and like essentially, like I bet some of the people who, started this had like the best intentions. And I feel like a lot of, medical policies are unfortunately like done from this like utopians like sort of view, and they don't really take like human nature into consideration. And like if you look at history, like people, take advantage of other people. They take advantage of programs. And like this one here, I mean, if you know that you can get 30 to 40 Dilaudid pills a day and you only need, 2 to 4, or even if you need 10, well, I mean, you can get 30 to 40 pills free and then put them to the street. And I think it is important for people to know that this number. So in 2019, London police seized 850 tablets of hydromorphone, and 10% of those were Dilaudid 8 milligrams, which is equivalent to the safe supply opioid. And in 2023, London police seized 30,000 tablets of hydromorphone, of which half, so 15,000, were Dilaudid 8 milligram pills. So like we're talking about over like a 15 times increase in Dilaudid on the street. And then again, that's just from like the stuff seized. Like it's probably even worse than that. So like we really don't even know the true numbers of how much, Dilaudid that we've really put on the street. But, even those numbers there are absolutely crazy. And that's just in 4 years.
This year, there was a press conference on July 15th where the London police chief, Tai Trung, said that they've already seized 12,000 pills that Dilaudid 8 milligrams that they can directly link to safe supply. So that's been a question. Has it been just pharmacies being robbed or other physicians, prescribing and having their drugs diverted? I mean, it's hard to get medication for chronic pain now, or even palliative care. So it didn't make sense to me. But what the police chief was able to identify is that 12,000. So last year they were saying 15,000 in the year. I think that's an underestimate. But this year they've actually already said it was 12,000, almost 12,000. So just a little under 12,000 by July. And they were absolutely able to say that it's being used as currency, that it is being used to fuel fentanyl, to fuel the fentanyl crisis. There is no doubt now this is being used to fuel fentanyl, and it is now in the hands of organized crime. So now, and I don't think when it started, I'm sure it wasn't, and now it is. But back to your comment about people selling it, if you think about how desperate someone is to sell their body, getting a pill and selling their pill is safer in a way. So not understanding the needs of people and then providing them with something that can give you a profit, but the profit margin's gone down. The police chief said the pills were $2 to $5. I've heard from multiple sources that the pills can be as cheap as $1, which means your profit margin's gone down. So you have to be asking for more to keep the same amount of profit. But that just means you're flooding the streets with more and more and more drugs. So we've created an absolute catastrophe, an absolute crisis.
And when you look at the numbers, like obviously, like it's organized crime is going to get involved in this way. Like because if you have so many patients who are getting like, and again, the number is just insane, like 30 to 48 milligram Dilaudid per day. Like, again, like to put that in perspective, like you took 2 milligram. I mean, I'm sure you took it several times, but your highest dose was a 2 milligram Dilaudid pill after you had both your hips replaced. And so like 8 milligrams, like that is an insane amount, like 5 Percocets. Like, I mean, 1 Percocet for most people causes like significant like psychoactive effects and changes in their overall body and their mental state. And so, you know, one of those being equivalent to 5 is just like absolutely crazy. Like, I bet if, you know, we took one of those before we started this podcast, we'd probably be both on the floor right now, right? Like not even being able to like comprehend each other. So, you know, it's important for people to know, like, not just the total amount that they seize, but also too, like the actual drug that they're seizing, like, you know, so 30,000 tablets of hydromorphone, like that's would then be equivalent to, you know, 150,000 of Percocets, right? So it's absolutely crazy how much is being put out there. And, you know, I don't want to maybe pick on one person. I won't say her name, but, you know, there's one person out there who's, I guess, the head of the program of London. You know, she's very vocal about, you know, saying that there's like disinformation about, this program, and that, you know, people need to understand that this program's working. But like, I don't understand where this person's getting her data from, why she's saying things are disinformation. Like, what disinformation have you seen, if any, on the internet regarding like safe supply program? And like, what is she essentially talking about?
Well, I think we have a different opinion
Okay.
of what disinformation is.
Yeah.
For example, the Unintended Community Health is a lead in a national organization, a national group of a safe supply providers, and they actually encourage other people to prescribe safe supply, and they have a statement that diversion is good, essentially, that it is compassionate sharing, and that we should we should reframe diversion as being a good thing. And I think that is a tragedy if people actually believe that there can be some compassionate sharing. That is a minority of what diversion is. And that still, by the way, is diversion. But the amount of diversion and the amount of people that have been harmed by the program. And I think it's really important. One of the things we haven't talked about is just how addictive opioids are. That's what got us into this mess.
Mm-hmm.
So we've now flooded the streets with a cheap drug. It's cheaper to buy a D8 than a tall boy.
Wow.
And I'm hearing over and over again from people who are working in addiction facilities that they were seeing younger and younger people, 15, 16-year-olds, and sometimes younger. I've had patients younger. And they're now so readily available. They're easy to hide. It's easier to walk into your house with Dilaudid pills in your pocket than with a 6-pack of beer, or even smoking cannabis. People can tell you've smoked weed. And so it's an easy thing to hide, and it's cheap. But if you think about it as a recreational thing, that, you know, yes, and there was a comment about by the same person that kids will experiment with everything. They'll experiment with safe supply. But when you're experimenting with something, we also learned, and I'm sure that during the opioid crisis wasn't the first time we've learned this, we keep relearning it, but it doesn't take long to develop dependence, to get neurochemical changes in your brain that lead to dependence on opioids. even after 3 to 5 days, people can start getting a dependence, which means when the drug wears off, they get withdrawal. And withdrawal is a horrible experience. People get nausea, vomiting, diarrhea. They can feel like they're going to die. They get a rapid heart rate, and they're chasing that feeling with another dose. So rapidly. So it's, in the time period that other drugs you can be experimenting with, you can get high, they can have risks. Other drugs have risks of addiction. Opioids can get you physically dependent and essentially addicted faster than other drugs of abuse that would see in young people.
Yeah, and just a
And
couple notes on that. Like when I was young, like the only thing like 99.9% of people experimented with in my high school was like alcohol and cannabis, essentially. And part of that reason was because those were the things that people could get their hands on. Like opioids wasn't a thing. Like I didn't even know what that was like when I was a teenager, But now, I mean, kids can get their hands on everything, and I think that's created like a massive issue. And then the other important part too, I really believe that, hormone optimization is really good for overall health. And a lot of people are unaware that opioids just kill people's testosterone levels. And when you don't have testosterone, it really does screw up your motivation, and it really does change your mood, and it makes guys unmotivated and not willing to work, and not willing to work out. And when it happens when it's older, that's terrible. And I'm sort of just like thinking in my head now, but like I could see that there be potentially maybe even permanent, I don't know this for sure, I'm just speculating, but maybe there could be permanent hormonal changes for some of those kids, because they're not getting the appropriate amount of testosterone, maybe not getting the appropriate amount of DHT to, proliferate and grow like during their adolescence, and to develop those, masculine features. And so, I think that, it's just something that for whatever reason, like a lot of people are unaware that opioids really drive down testosterone. And I think that could be even worse for someone who's 15 or 16 who's developing, as opposed to say someone who's, my age 39, who's already, fully developed.
I think that's a really important point. And also just the effect that opioids have on executive function.
Yeah.
So for a young person that's developing, their brain is developing, and their ability to make good decisions, good choices, safe choices is absolutely impaired by being on opioids. So having a program that just keeps giving out opioids and to somebody who's not in a position of making good choices, because the drug itself is causing damage to their executive function, the easy thing is to just keep taking them. And even if they weren't profitable, but being profitable makes it a very hard thing to get off. So having the ability to make the decision to get off when they're actually impairing you in the first place, and impairing your relationship with families, your relationship with stability. So things that help to keep you stable, it's interfering with that. And then we have a program that kind of keeps you dependent on the program and keeps you unstable. Um, so many of the people that I saw I used to live in Old East Village, and people in the encampments, a lot of the people I saw there, I knew were housed and had been housed. Now, homelessness is a huge, important problem.
I agree.
But when you add to it people going to encampments behind the pharmacy where a lot of diversion started, kids were leaving, young people, youth were leaving apartments or their parents' house to be at a place where the diverted drugs were the cheapest, because they were the cheapest in the core. And as you left the core, they got more and more expensive. And then add that to something that's actually affecting your mood, your ability to interact with your family, your ability to make decisions, and then saying, oh, it's okay, they should be allowed to stay on the drug if that's their choice. Well, the choice isn't theirs anymore. The drug's choosing it for them. And that's where healthcare providers need to be able to work with people and understand that they are in a state of addiction, and not be judgmental, to absolutely meet them there, meet them where they are, but not keep them there. Meet them where they are and help facilitate a trajectory that can include, through whether it's motivational interviewing or working with somebody, a road to recovery as an option.
Yeah.
And what I've seen is that road's been blocked by healthcare providers not really understanding what addiction is, and that are keeping people in an addicted state, and really not working with people to get into a state of recovery that really we need. And the funding for recovery programs is not improved as this effect of opioids has absolutely dramatically increased. We have not enough access to appropriate opioid agonist therapy and recovery programs. And certainly to be able to recover from something, it's difficult to recover from an opioid addiction. You need support. You need support of the healthcare providers that are giving you care to work with you, that you can get through this.
Yeah, it is difficult. And I mean, again, I am not, even though I prescribe cannabis, like my patients, mostly everyone just takes CBD oil during the daytime, and then at nighttime they use THC with the CBD to help them, sleep at night. Like, I don't believe it's like, something that's going to save everyone. And I don't believe that, smoking high THC, especially during the daytime, is good if you want to, really go out and get things done. That being said, though, like, I do see it as something that's like an alternative to opioids, but at the same time, like, there's no like really like center for weed addictions. I mean, there may be some, but it's because like it's not that difficult to get off. Like, it's difficult for some people. I don't want to make it out like if you have a high THC tolerance, it's like really hard to get off. But like, most people can do it kind of on their own. With opioids, like, it's really hard. Like, like THC withdrawal is not the same as an opioid withdrawal. Like, it's not even close, right? And the other thing is, like, you can't die from THC. Everyone kind of knows this stat. Like, yes, if you smoke it and jump off a bridge, you can die, but you can't die from actually ingesting it. The lethal dose, the LD, is too high. So, it seems like, there are some alternatives out there, like, for these people that could, potentially have harm reduction. Like, my fiance actually works with Dr. Sidhu, and at his clinic, and they, give methadone, and, sometimes they do, well with some of their patients, sometimes they don't, like sometimes they don't. That's just, the way it is. That's the reality. You're not going to have 100%, rate of curing your patients of addiction. But I do think that, like you just said, like, the funding for these patients for other centers is not good. And I do think that the homelessness issue is also going to contribute to it. So, to fix this whole issue does seem to be, exceptionally complex. And I'm not, saying that we're going to be able to hash it out here in an hour, but I do think that, reducing the amount of opioid supply and from like the safe supply program, and then potentially, like, I think using cannabis as like more of a legitimate way to reduce people off opioids, should be, considered. And I think there's like some pretty good research and data on that. And so, going forward, like, what do you think should be, I guess, the solutions, and what should we do to combat the addiction in London going forward?
I think that's a really good question. I want to just point out one thing before I address that, and just that we were talking about the changes in the brain with opioids and how it's different from cannabis. And that made me really think about how the more opioids you take, the more you need to feel normal. And to feel euphoric, you need to take more. So you start chasing this, that you're needing to take a higher dose or a stronger medication. So we know from research that people who start with abusing or experimenting with prescription opioids, they are at higher risk of developing riskier behavior, including injection drug use, and of increasing to riskier drugs. So they're a much higher risk of going on fentanyl. And I think this is important because sometimes parents don't know the journey their kids have been on, that they started with prescription opioids, and then got used to that, increased that, and then took fentanyl. It is much more likely that a child or a young person, a youth, dies of fentanyl overdose that started taking hydromorphone, prescription hydromorphone, then jumped right into taking fentanyl. And I think that's important because I think people didn't know their journey of their child. So when a person dies of an overdose, it does not tell the journey that they took to get there. So you're absolutely right. Cannabis is not going to take you on that journey to an overdose. But starting with prescription opioids, you might 5 years later, 2 years later, die of an overdose of fentanyl with no hydromorphone in your system. And then they can say, see, it's the fentanyl, but it's the journey that got them there.
Yeah.
And that is so important. And that's what I'm seeing. And that's what I'm hearing over and over again by both patients, by people getting diverted drugs, and by other healthcare providers in addiction, that their patients using fentanyl started with prescription opioids.
So
And
essentially, Dilaudid or D8s, they are more or less like a gateway drug to fentanyl.
absolutely. And I think that's important to say that because cannabis has often been talked about as the gateway. And it's such not a gateway. I mean, in the sense of what we're seeing now.
It's just
The
because that's what people try first. People try alcohol
Yeah.
and cannabis first. Like that's just,
Yeah. And if that's not a good enough high for you, you're going to keep progressing, but not because you have to, but because it's not meeting your needs in a different way. Whereas with opioids, you have to get the same effect, to feel normal, you have to take more or stronger. So it's a different journey. Once you get on it, you either have to get into recovery or you're likely to keep progressing in higher use or switching into fentanyl. And I think that's important because I have my youngest child just turned 32. So I have kids sort of between 37 and 30, 38 and 32. And when they were in high school, same thing. There was a lot of drugs, MDMA, so Molly, ecstasy, even crystal meth and alcohol and cannabis. But opioids were really rare. And the other things, absolutely, they can be dangerous and people can become addicted. But and with cannabis, there can be certainly a psychological addiction. But the ability to get off those drugs, opioids are absolutely the most difficult to get off. So you can smoke weed for quite a while living in your parents' basement and then decide that you're going to get on with your life, and you can. But when you start on a journey of opioids, you don't get that choice. You could die from the complications of it. You can die from the overdose. You can die from the infections. And then you're in a position of having a much, much, much more difficult medication, more difficult drug to get off than if you'd started on a path with a different drug.
Yeah, no, that's very interesting. And I just want to come back to, we always hear about, and I agree, like, people under 25 should try to stay away from high THC. Like I do think, CBD is something that can be used even in kids. I think it's actually a great medicine. But, we know that high THC can have harms on the developing brain, but we don't hear too much about, the opioids having harms on the developing brain. And I'm not sure, Dr. Koivu, if you know anything specific about like what it's doing to a developing brain and maybe the consequences of that.
Well, and as I mentioned, it's really, we do know that it affects executive function and the development of executive function and ability to make choices and decision. That's huge.
Yeah.
So it affects your mood. It affects your ability to interact with others. Those are huge effects that really impair your ability to interact with others and to make choices and to get an education and to continue to go to school, to go to work. If you have children, it can certainly limit your ability to parent, and often is a reason why people lose custody of their children. So we do know that using opioids at a young age in high amounts is dangerous. I think that what we haven't been prepared for is what we're about to be seeing which is the number of people. Because even back in the old opioid crisis, opioids were expensive. So even during the Purdue days of opioids being on the street, they were still, diverted opioids were still relatively expensive compared to other drugs of abuse, compared to cannabis, compared to crystal meth, compared to ecstasy, compared to alcohol. Opioids were expensive. And I've had my kids tell me that, yes, opioids were in school, but they were expensive. And so they weren't used a lot. And if they were, often it was by people who were socioeconomically better off, but they weren't a drug of abuse in the same way because they were expensive. Now, obviously, a lot of people started using them, but by that, youth particularly are affected by price. We know that. We know that with tobacco. We know that with alcohol. So there can be lots of reasons why people who are older start using opioids. But now that they're really inexpensive, I don't think we've ever seen that before. And really understanding that people are leaving their homes to be closer to the pills that are being diverted. I don't think we've seen that in the way that we're seeing that now. And as I say, homelessness is a huge crisis, but when you add that, people who are leaving homes to get in encampments to be close to diverted drugs, we're making it so complicated. And then once they're there, they lose their ability to function and to get back home. And now they're homeless in a way that they can't get out of it. So there's so much happening that I don't think we've really understood or studied or even knew we had to study, because it's never been $1, $2 to buy a D8 ever. This is groundbreaking.
That's a very, very, very good point, though, because I did look at too, like they had 5 summary points on that 2023 paper, and one of them was that they wanted to address homelessness. And I don't think there's anyone out there who says that we don't need to do anything to address homelessness. We need to do something. Absolutely we do. But it seems like if we want to address homelessness, the first thing we want to do is not increase it. And so it seems like this program almost drives people to homelessness. It's like D8s are a gateway to fentanyl, and that leads to a homeless life. So it's like, it's not only a gateway drug to fentanyl, it's a gateway drug to homelessness. And so, we talk about this like triple threat of like homelessness and then drug addiction, mental illness. Well, like it seems like you can, the initiator of all that, the gateway, so to speak, could be D8s or Dilaudids. It's kind of crazy.
I agree. And I think that's what we're seeing. I know that that's what I'm seeing, that so many people have told me that and I know that I'll meet, at times I've met when people have had a severe problem from living in an encampment. I'll meet parents who are living in London or southwestern Ontario who are quite affluent and wanted their child back home, but for various reasons of not being able to make executive decisions, not being able to function, sometimes not be able to function in a home, they now are in a position of kind of being drawn into a state of addiction, mental health, and homelessness that probably could have been prevented. And I think going back to, you asked about what do we do now? And I think what I really always try to go back to is that we've talked for years about 4 pillars of the strategy to help with addiction. And the 4 pillars are prevention, treatment, harm reduction, and enforcement. I've been criticized when I used that word on a podcast once because somebody thought I invented it, but no, those are the 4 pillars. That's not me coming up with it. I think, unfortunately, harm reduction was the perhaps underdog at one point, but now has just overridden everything. And benefits of harm reduction have been in collaboration with the other pillars, not on their own. There has not been a study that actually shows that harm reduction alone decreases overdose deaths. And in London, they're claiming people in the program have less. I think that that's questionable for lots of reasons. But if we look at overdose deaths within the community, they've gone up a lot. London, the deaths of overdose have gone up significantly more. So in 2016, we were kind of the same level as Ontario. Before that, we were sometimes a little bit better for overdose deaths. Our overdose deaths compared to the rest of Ontario have gone up.
Actually, but by 2022, the opioid-related mortality in London had risen more than 4 times higher than the rate in 2015 and 40% higher than the rate for the province of Ontario. So, you're absolutely right. The data backs up.
Yeah, absolutely. And correlation doesn't prove causation, but there is no other program that I know of in London or anything else that's happened in London differently than the rest of the province that could account for it. And to say it can't be from safe supply because I can't prove it is absolutely ludicrous because, and to be honest, I'm worried that the difference is going to start being less because there's so much more safe supply in other places. So, and a lot of safe supply is, and I hate that term, but a lot of this prescribing is now being done by people who aren't even in funded programs. It's not being monitored at all. The programs, the people involved in the programs have absolutely been encouraging others to prescribe. And now, in addition to London Intercommunity Health, there are 3 other clinics that are prescribing a safe supply approach to medication that aren't listed anywhere, that you can't find by Googling them. And they're not tracked by the CPSO either.
What?
So, no, the CPSO does not keep a record. You do not have to identify yourself as being a safe supply prescriber on CPSO. It's not one of the requirements. They have not been awake. And as far as, I think there are lots of places that have fallen, not lived up to expectations that I would have of monitoring this. But the CPSO has been aware of diversion, and yet we now have diversion to the point of organized crime involved. It has not been following or tracking the risks of diversion at a level that I feel our college should be accountable for.
Yeah, I think
that's a huge problem.
Yeah, I think so too. I mean, the college is supposed to, again, protect the public is their kind of number one theme. And, that's what they're there for. And by not overseeing like safe supply, I mean, that is not protecting the public. And I don't think anybody would disagree with that statement. Like if there's a huge amount of Dilaudid number 8s going out and the CPSO is unaware of this, like I think everyone would be shocked to hear that and would think that it's a huge mistake. So that's.
I first spoke to the CPSO the same year I first spoke to London Intercommunity Health, and that was 2019.
Yeah.
So I think it's very unfortunate that it hasn't been followed and monitored. But
go ahead.
I think sort of back to kind of those 4 pillars.
Yes.
With prevention, we also know, there are definitely social economic factors that are involved in prevention. But we also know from the opioid crisis that when it's readily available, everyone's at risk. And the biggest risk to developing an addiction is availability of a drug and the price of a drug. So we know that having cheap, abundant drug, whatever it is, increases the risk that people will use it, people will take it, and people will become addicted to it. And now we have a cheap, abundant drug that is very quickly addictive. And it's still really cheap and abundant. And there's very little support to get off of it. And it's very easy to stay on it. And one thing that we haven't addressed is that people who've been stable on other programs, including opioid agonist therapy, including methadone and Suboxone, have gone off those treatments to go back on Dilaudid, either because of the euphoria.
I know this story.
Or the price.
Yep.
I had patients absolutely stable in hospital. And the moment they were discharged, they went back unsafe supply and told me on their next admission, when they'd been doing really well and they told me they were going to stay in recovery, and they've said the income that they got from safe supply was just way too much of a draw to stay on opioid agonist therapy.
Yeah. So
So
literally, though, I've heard this story before. People will inject themselves with fentanyl so they can get into the safe supply program so that they can start not only using Dilaudid maybe for themselves, but just to have the financial backing. Because even if it's $40, okay, that's $40 a day. In a week, it's $280. You're over $1,000 a month, right? And people don't want to give that up, so they're willing to inject themselves with fentanyl to be able to get that money.
I don't believe they have to. I don't know that the program requires you to be on fentanyl to get into it. It
Okay.
didn't used to.
Okay.
So, I mean, I could see people saying that or even think they needed to do that, maybe even doing that. I believe you have to test positive for an opioid.
Just
But if
an
you even look at the
opioid.
original data,
Okay.
it was just hydromorphone anyway that many people tested positive for. They have to say that they have an opioid use disorder, they have an opioid problem, and they probably now have to test positive for an opioid. And I can see people starting an opioid just so that they can get into the program, whatever that is, including doing things that are risky.
Well, I mean, if you're in organized crime, like, if I was a boss in organized crime, I'd be like, hey, guys, you three guys go to this center, tell them that you have a little bit of opioid in your center, bring me back the pills, I'll sell them, I'll give you guys half, I'll keep half. Like, easy. You know what I mean? But like, for whatever reason, people who make up these policies usually have these like very, very like utopian views that people will like never do anything wrong. And it's like, the world just doesn't work like that, unfortunately.
The other thing too, though, I think I want to mention because is that when Dilaudid, the program started, a lot of people, we knew that people were injecting. It was their pills. They're meant to be taken orally. They're meant to be swallowed. They're supposed to be digested. They're not designed to be injected. And yet most of the people that they were prescribing these to were injecting them. And that was the expectation that this pill was going to be injected. And they were given instructions about injection. I started seeing a lot of infections. I saw more spine infections. Now, I've had people criticize, yes, you can get spine infections from injecting other drugs, but I've never seen it in the volume that I've seen related to injecting Dilaudid. Is it the pill itself? I think there's a property of the pill that is probably part of it. We also know that the more you inject in a day, the more likely you are to get an infection. This is a short-acting substance that people are injecting a lot. And then when you're injecting in like an encampment with no sanitation, your risk of getting an infection are really high. So I've seen the most horrific infections I've ever seen in my life, particularly spine infections that have led to paraplegia or quadriplegia in people who are injecting Dilaudid. That's known on the street. From somebody who's already living rough, whose life is evolving or revolving, I should say, around drug use. A form of harm reduction can actually be to smoke fentanyl. So I'll have people say they don't want to risk the infections they could get from injecting Dilaudid because those are horrific and can be disabling. They'd rather take their chances with an overdose, knowing that probably somebody's going to be able to reverse it with naloxone. They'd rather smoke fentanyl than inject Dilaudid. And they see that as harm reduction. I'll have people proudly tell me they don't inject, they just smoke fentanyl. And the reason that's important is because we don't understand what's happening on the street. We can't address it. And if we're thinking giving out a pill to inject is a form of harm reduction from fentanyl, and yet people are saying, I don't want that. It's going to give me an infection. I'd rather smoke fentanyl. We're not understanding what we're doing. And I think that's a huge issue. Supervised injection sites are literally injection sites. Most people can't smoke fentanyl there either. We are not addressing what's happening on the street or truly meeting people where they are.
And just a point on that. So there is, from my understanding, one injection site in Toronto, and they're trying to open up one in London. Is that correct?
We have a supervised injection site
You have
here,
one.
but
There is one here.
consumption,
Okay.
there are quite a few all over the province. There's certainly several in Toronto, but consumption sites where you can actually smoke fentanyl is rare.
Okay. Yeah.
The one in London, I know they're trying to get fume hoods so you can. But even addressing that, I'm not sure that that's people generally smoke in a more communal way than just injecting would be. So I'm not sure that those are going to address the needs of people. But I think we've started people on a drug. They've recognized that that drug could give them a bad side effect that they don't want, even if it's being denied by people who are prescribing it. Because I've been challenged on my, the infections that I've seen, and all I can say is that there is such a correlation between people injecting Dilaudid and getting a severe infection that I didn't see before in those amounts. People got spine infections, people got other types of sepsis and joint infections. I just saw a lot more in people either in the program or getting diverted Dilaudid. As I say, whether it's from the property of the pill or from the number of injections or whatever it is, it's still a risk factor for a severe infection. And the people are aware of that. And it's a huge thing. It's not this lovely place of compassionate sharing. There is a hierarchy in the community. And if you've been a high in the community in the hierarchy and then come into hospital and leave with a disability that leaves you unable to walk properly, you've changed your position in the community in a way that I've had patients express that they're afraid to be discharged because they know that that's a change. And so they don't want to be in a position of, people don't want that. Once you see a few people with that type of infection, as they say, people would rather take the risk with fentanyl, which just drives it even more.
That's
we're giving it a
crazy.
drug, people can exchange it for fentanyl, and now they see fentanyl as an alternative that they'd rather die from an overdose than get a horrific infection because they believe they can be saved from that overdose, but not necessarily saved from that horrific infection. So it's about balancing risk that we're not taking into consideration.
I'm really happy that you mentioned that because that was one of the things too that I read in the National Post article. And for everyone listening, it's a great article with Dr. Koivu here today. So if you just Google Dr. Sharon Koivu, National Post, it'll come up right away. And she does explain in that article all these spinal infections that are from the Dilaudids. And yeah, I guess people kind of just think in their head, I'd rather just, smoke fentanyl and maybe overdose or have someone, give me naloxone than inject this Dilaudid and potentially become a, quadriplegic or paraplegic, which is absolutely crazy. I know we only have so much time here left, but there's one thing that I kind of wanted to go over with you today at the summary of this 2023 paper of the SOS program. So one of the things that they advocated for, I'm a little bit surprised. I just kind of want your opinion on it, I guess. So it says they're advocating for increased pharmaceutical options for prescribed safer supply programs, including options for smokable medications. Clients indicated diverse preferences for prescribed opioid of choice, with approximately 1/3 indicating preference for either regulated heroin or regulated fentanyl. Given the high rates of smoking as method of use compared to injecting and oral use, pharmaceutical options that can be smoked, example, powdered fentanyl and heroin, should be considered. So it sounds like they want to, essentially allow patients to be able to inject themselves with fentanyl and heroin. It's, what do you make of this?
I think that, the issue becomes about not being witnessed. We've had programs that have been successful with injectable heroin and injectable hydromorphone in a witnessed environment where we give somebody an amount of a drug and we know they take it. I think that is an option for people who have a severe addiction that nothing else has worked. And that's not where we are when young people are getting safe supply. But we know that witnessed programs of opioid use can be effective in certain circumstances. Now, witnessing smoking fentanyl is probably going to be something that would be tricky, but we do know that a witnessed injection is something that can stabilize people and doesn't cause harm. I believe, as a retired police officer said, once you're causing harm, you cannot claim your harm reduction. And this is not harm reduction when it's harming so many other people. So the Safe Supply program is not harm reduction. A witnessed program can be. But I think what's more important is we've lost sight of recovery and treatment.
Mm-hmm.
Keeping somebody addicted and throwing them cheap, free drugs can block their ability to ever have an opportunity to get into recovery. When supervised injection sites started, and I was involved in the town hall meetings of a supervised injection site in London, I actually moved to Oldies Village to be able to be in a community that might get a supervised injection site so I wouldn't be NIMBY and I could be promoting harm reduction. I support harm reduction. But part of the supervised injection site was supposed to be a place people could connect with healthcare providers in a safe, non-judgmental place and be connected to referrals for resources to allow them to get into recovery and treatment, not as an end point. And the same with Safe Supply had been, I've had people in London Town Council say they thought that it was a stepping stone towards recovery. It has not been used that way. It could be that you could be on it for 6 months, you could be tapered. I mean, there are ways to have a witnessed program where the drug is tapered and then you're put on opioid agonist therapy. It could have been, if we'd addressed the problems instead of kind of ignored them or overlooked them, we could have created a program that I think would be less harmful and still as helpful to the people that it's helped.
Yeah, no, that makes complete sense. And I just want to bring back to this one point though, because I know again we only have a couple minutes left, but this is from their own data, and like it's kind of crazy. But it says in 2022, 17 of clients reported injecting street acquired fentanyl, and 59% reported smoking street acquired fentanyl. In 2023, 26% of clients reported injecting street acquired fentanyl, and 73% reported smoking street acquired fentanyl. So those are people within the own program. So like the amount of people injecting fentanyl went up and the amount of people smoking fentanyl went up. So again, like it just comes back to this question of like, because I think people want to know, like there was, I think $6.5 million put into this program. The data here indicates that the people within the program are getting worse. And then we also know that a lot of these drugs are being diverted to the street. So like, how did we come to the conclusion that we should give them another 1.7 million? Like, does this make any sense at all? Like,
I think, unfortunately, I'm going to answer that one in a way. I feel like it's become very political instead of understanding science, that supporters have kind of doubled down and said, and looked at the good without recognizing the harm. And I like the comparison I make is thalidomide. You might, for anybody who's old enough to remember thalidomide, if a benefit is all you're looking at, thalidomide was a medication that really helped nausea in pregnancy. And nausea in pregnancy can be a very serious thing. It can lead to a growth retardation so that you can have problems with the pregnancy, problems for the mom. Thalidomide worked. It was absolutely, if all you look at was did it help nausea of pregnancy, it worked. But if used in the first trimester, the children were born with limb deformities where they had short arms or short legs severely. And we decided the harm outweighed the benefit. So saying something's harmful doesn't prove there's no benefit, but saying something has a benefit doesn't prove there is no harm. So there could be some benefit for some people in the program, but the harm is astronomical and significantly more. And those benefits could still occur in a witness program, unless those benefits are literally from diversion. So if the benefits are from diverting the drug, then you won't get the benefits if it's witnessed. And if the benefits are from the wraparound services, then the wraparound services are what's needed. I've heard people in the program saying it shouldn't be given out at places that don't have the wraparound services. Well, you can't have it both ways. Is it the drug or is it the wraparound services? So we haven't teased out why it's beneficial to the few that it is. But I'd say statistically, for 2 that you help, 3 you hurt. And we don't even understand why they're being helped. So we've got this program. Why are they still getting funding? I think that thinking that somebody who is diverting a drug and then giving you information about whether they're benefiting from it or not it's not. Self-reporting has downsides. People can be diverting their drug because they have to too. You can be forced to and still report that it's wonderful and you're having no problems, and people aren't reporting that they're diverting. So to just look at self-reporting as our evidence, Carolyn Bennett was saying there's all this evidence. Well, no, the evidence is self-reporting and limited. And I have had people who are trying to say there's a problem have received no funding. And in healthcare, as you know, as a physician, if we identify a problem with a drug, an adverse event from a drug, we're supposed to report it. We're not supposed to have to prove it. We're just supposed to report it, and somebody's supposed to take it seriously, not ignore it. That's not what's happening. Many people are saying this is a problem and they're being ignored. But the other thing with all that funding, and I want to say this before we is that we haven't increased our funding for all the other things for treatment. We have not got a medical withdrawal management center in London. We have limited, the Rapid Access Addiction Medical Center is not open 7 days a week. We need to have access to opioid agonist therapy quickly. We need to have access to Sublocade. The same political parties that have been promoting safe supply have come up with a universal drug plan that didn't include opioid agonist therapy. And I think if you're going to say we have a crisis that you're going to spend a lot of money on doing, giving out safe supply, somebody shouldn't have to stop their Sublocade because they can't afford it. And Sublocade is covered if you're on ODSP but it's not covered from most drug plans. So for a working poor person, it's not necessarily covered. And we need to have access to opioid agonist therapy. We need to have access to treatment programs, and we need them in the city. People shouldn't have to leave town to get into a recovery type of, whether it's residential or any type of treatment. That needs to be enhanced.
It should be easier to get treatment than it should be to get D8s off the street.
Absolutely.
Like that's what it like boils down to. And it's terrible.
We haven't worked on we haven't worked on prevention. We've ignored treatment, and we've made enforcement a bad thing.
Yeah.
And enforcement, we now know that a lot of fentanyl is made in Canada. It's made here. This isn't about coming from another country. This isn't about China. This isn't about Colombia. It's made here. And it's, people are profiting from this because we're not dealing with enforcement. When somebody's drunk and disorderly, you can take care of them. We now continue to let them just smoke their fentanyl, even if it's seen. We're not trying to decrease fentanyl. And I don't believe anybody should be criminalized for having an addiction, but trafficking has to be. And it should be safe to live near Old East Village where diversion is taking place. It should be safe to live near a supervised injection site. Enforcement doesn't have to be a bad thing.
Yeah.
It should help the community, and we shouldn't look at it as it's an important pillar that we've absolutely tarnished.
Yeah, I think that boundaries are very, very important. And people seem to think now that if you're someone who has no boundaries, you're empathetic. And it's that's not the case. People, you need boundaries, for everything, with your diet, there's got to be some level of restriction. You can't just eat anything you want. There's got to be some level of restriction. There's got to be some level of restriction with drugs. There's got to be some level of enforcement, some level of personal responsibility. And again, meet them where they are. Like you said, don't judge them. Don't, you don't know what their life has been like. Like, you may have ended up in the same place, if you were in their shoes, and meet them where they are. But then once you meet them, don't enable them. Try to actually help them. And it's actually easier to just go along with it, and lazier just to say, oh, I'll just, give you this medicine, and, and I'm so empathetic, than to actually, challenge your patients a little bit and say, like, hey, like, do you know this is addictive? And do you know that if you take too much, like, you may not, do well. And then obviously sometimes the patient may get upset at you, but it's like, that's what's needed. And that those conversations are needed. And that's when you're being empathetic, is when you're actually trying to help someone. It's not like empathetic just to have like no boundaries and let the person do whatever they want, especially when we're talking about serious drugs like Dilaudid. And I know I've said a couple of times now, but is there anything in closing that you do want to say, Dr. Koivu?
I guess I want to say I'm relieved that the word's getting out more. I lived in Old East Village, and I was watching the encampments form, and I was watching some of the problems with sanitation. I was watching problems with, crime in the neighborhood. And the people in the neighborhood did not know that there was a safe supply program. They were blaming things that were happening from diversion on a supervised injection site. And they really weren't aware that a program giving out Dilaudid was happening in their own backyard, and that things that they were seeing were related to that. So being able to identify harms, you have to know that something exists. Yeah. And you have to know what that means. So I'm glad that the word is getting out more. The physician that we were talking about at the beginning has also identified that kids will experiment with safe supply. And I think that, although I don't know that she understands the ramifications of that, we can now talk about, yes, this is so abundant. It's in the hands of children. Well, youth. Children is one of those words that I think can have a different meaning depending on how you say it. But youth are accessing a drug that's highly addictive. We need to deal with it. We're seeing the fallout of a program that I absolutely believe people who started it meant well. And I think they liked the reinforcement they got from meaning well. But you're right. It's somebody who's executive function, whose decision-making is impaired by a drug, giving them more of a drug, that's not compassion. That is laziness. That is not really about caring about people. That's about saying, I've given up on you. To me, that's like palliative care. That is literally saying, I don't believe you can get into recovery. I'm just going to keep you addicted. And I've watched too many people actually be able to get into recovery that even themselves didn't see that coming until they were able to work through it. Something happened. There was something that motivated them. Yeah. But continued access to cheap drugs prevents a lot of that motivation when your brain function is impaired by the drug itself. So we need to address that. And we absolutely need to improve the pillars in harmony.
I agree. I'm glad you brought up those pillars, because that's very, very important, because 1 out of 4 is being addressed essentially. Yeah. Right. So, it's, we gotta do much better there. So thank you so much again for doing this. I really appreciate it. When that article came out in National Post, right away, I was like, I need to reach out to Dr. Koivu and get her on the show. So thanks so much again for doing this. You did a wonderful job. I think a lot of people are going to really appreciate this podcast. And thank you so much again, everyone, for listening. And as always, I'll be back again soon.